We'll cover cancer of the pancreas here, and in specific we're going to be talking about pancreatic adenocarcinoma. So this is the pancreas. Here you have a head, a body, and a tail, and the head of the pancreas sits in the C-section of the duodenum, which would be roughly your second part and your third part of the duodenum. The pancreas sits posterior to the stomach and also parts of the transverse colon. And it sits anterior to the major vessels of the abdomen, which include the aorta and the inferior vena cava. So here's our vignette. A 58-year-old man presents to your clinic complaining of abdominal pain and shortness of breath. He says he doesn't remember when it started, but both problems have been going on for at least a month or two. He points to his epigastric area. He has not had any changes in bowel habits or color, nor has he had any related nausea or vomiting. He describes the pain as dull and as a plus 4 out of 10. It radiates to his back. He denies cough, wheezing, and contact with sick. There is a 30-pack year smoking history. Patient consumes alcohol only a few times per year. He has a past medical history of type 2 diabetes mellitus, which is well controlled on metformin. On physical exam, you note mild epigastric tenderness, scleral icterus, mild jaundice, and a small palpable mass in the right upper quadrant, which I'll add is painless. No distension or rigidity, no hepatosplenomegaly, no peritoneal signs. Rectal exam is negative for masses or stool guaiac. Lungs are clear to auscultation in all fields. Heart rate and rhythm are regular. There's paleness of the nail beds and of the buccal mucosal membranes. He's lost 25 pounds since his last visit 6 months ago, which is unintentional. So what is our initial workup? It's going to be basically what we always do for abdominal pain. So CBC, CMP, amylase, and chest x-ray and abdominal x-ray. We particularly add the chest x-ray here because he's complaining of shortness of breath and that he's a smoker. But we would always include a CBC, CMP, amylase, and abdominal x-ray at the very least in a patient, an older patient, especially with acute abdominal pain. All right, and what do we get back from this? We get a CBC showing a hemoglobin of 9.7 with an MCV of 82.5, which is normal. He's got an ALT of 77, an AST of 40, so those are both elevated. Alkaline phosphatase of 205, and a total bilirubin of 4.2. His amylase is normal, and chest x-ray comes back unremarkable. The abdominal x-ray comes back unremarkable too. So here we have a patient who has abdominal pain with elevated liver enzymes, elevated alkaline phosphatase, a high bilirubin, but a normal amylase. He's also got a shortness of breath, but he's got a normal chest x-ray. He's also anemic, normocytic anemic. So what are we going to do next? The next step is going to be to get an abdominal or right upper quadrant ultrasound. 2 reasons. One, the most likely diagnosis here based on his labs and the fact that he has a mass in his right upper quadrant. So 2 reasons why we're getting an ultrasound. On ultrasound, we find dilation of the gallbladder, not surprisingly, because he's got a mass in his right upper quadrant, so that's more than likely going to be the gallbladder. There's no wall thickening of the gallbladder. There's also no gallstones visible. There's also a markedly dilated common bile duct and a 2-centimeter hypoechoic mass at the head of the pancreas with a dilated pancreatic duct. So whenever you have a patient with obstructive jaundice and a palpable enlarged gallbladder that's painless, no, he does have abdominal pain, but it's not at the gallbladder. It's not a painful gallbladder like you would in acute pain, or like you would in cholecystitis. Whenever you have a painless, dilated gallbladder with jaundice, like in this patient, the most likely diagnosis is a tumor, an obstructive tumor of some kind, not a stone. We'll talk about that in a little bit. So the most likely diagnosis here is pancreatic adenocarcinoma. And the reason is because he's got that mass at the head of the pancreas, as well as the enlarged painless gallbladder and the obstructive jaundice. So the next step would be an abdominal CT. That's going to give us a better picture of the cancer, if it is cancer, which more than likely it is. We will also do a CA19-9 titer. That's the tumor marker for pancreatic adenocarcinoma. And more than likely in this patient, because he has a picture of obstructive jaundice, we're going to do an ERCP, and that's going to be to place a stent in his common bile duct to relieve the jaundice. And the ERCP can be done for two reasons. Most of the time it's done palliatively to reduce the jaundice, but it can also be done, and is always going to be done while we're down there, to get a biopsy. You don't have to get a biopsy to diagnose pancreatic adenocarcinoma, but if you can get one, you may as well. So this patient will likely get an ERCP because of the obstructive jaundice. Note, if you have a pancreatic adenocarcinoma of the tail, you're probably not going to get jaundice. So in that case, you probably wouldn't do an ERCP. You wouldn't do an ERCP at all. Okay, so pancreatic adenocarcinoma. So this is an infiltrating ductal carcinoma of the pancreas. This is a cancer made out of the ductal epithelium, which, remember, the duct is what carries the pancreatic juices over to the common bile duct, where it then becomes the ampulla of Vater. And this ductal epithelium becomes cancerous and then infiltrates the parenchyma of the pancreas. And pancreatic adenocarcinoma makes up about 90% of all cancers of the pancreas, 80 to 90%. The rest are either benign tumors or they're cystadenocarcinomas, or they are lymphomas. But the vast majority, especially in this country, are adenocarcinomas. Whenever you hear pancreatic cancer referred to, you should assume that they're referring to pancreatic adenocarcinoma. This is the fourth most common cause of cancer death in the United States, and this is a very, 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 very deadly cancer. And most of the reason is because once it causes symptoms, it's far too late to successfully cure. It causes about 30,000 deaths per year. Typically, it presents in the mid-50s to 70s, and there's a higher incidence among blacks and Jews and among males compared to females. Some of the risk factors include smoking, obesity, and a diet that's high, very high in red meat compared to fruits and vegetables. Now that's not all meat, that's just red meat, so beef. Then the presence of chronic pancreatitis is a risk factor for adenocarcinoma, as well as various diseases that one can already have, such as diabetes mellitus, both type 1 and 2, multiple endocrine neoplasia, which, remember, puts you at risk of tumors in the pituitary, the parathyroid, and the pancreas. So men type 1. Familial polyposis syndromes, those are all the syndromes that give you polyps, particularly in your colon. So like Peutz-Jeghers syndrome, familial adenomatous polyposis, etc. And then the BRCA mutation. Remember, the BRCA mutation, what does BRCA stand for? It stands for breast cancer. So a patient who has a family history of breast cancer, they are possibly at increased risk for pancreatic cancer, because if they have a strong family history of breast cancer, it's possible that that's related to the BRCA gene. And men can carry the BRCA gene too. They're just not likely to get breast cancer because men are far less likely to get breast cancer than women. But what men can get is pancreatic cancer. So you want to ask for a history of any kind of cancer in the family, and if breast cancer is common among the women, then perhaps that patient does have the BRCA mutation. If they're known to have the BRCA mutation, well, then we know that they're at risk for pancreatic cancer. And then another thing that I didn't put in here, a family history of pancreatic adenocarcinoma does confer upon the patient an increased risk of developing it themselves. Unfortunately, like I mentioned, the symptoms don't become noticeable until relatively late in the course, usually when the cancer is big enough to cause obstruction of the common bile duct. and the patient doesn't present until the tumor has metastasized, usually to the liver. Usually it goes first to the regional lymph nodes and then to the liver. And by the time it's gone to the liver, there's nothing surgically we can do to resect the cancer. The 5-year survival rate for metastatic cancer, and by metastatic I mean not to the local lymph nodes, I mean to the liver and extra-abdominal sites, is only 5%. For resectable tumors, meaning tumors of that are localized to the head or tail of the pancreas, or just to the regional lymph nodes, the 5-year survival rate is 20%, so still not very good. Classically, the patient with pancreatic cancer presents as an obstructive, painless jaundice, like this patient did, perhaps with weight loss, and that can be for 2 reasons. One, because you're obstructing the common bile duct and you're obstructing the pancreatic duct as well, you're not getting lipase into the duodenum, and since you're not getting lipase into the duodenum, you're not going to be able to break down fats. That's going to cause steatorrhea. Another thing is that cancer just has a tendency to cause weight loss just out of being cancer. So that's just a feature of cancer, is weight loss. So 2 reasons go into the weight loss. And then, of course, on ultrasound, as we saw, classic sign is a pancreas that's non-tender, a gallbladder that's non-tender and dilated. That's called the Courvoisier's sign, or Courvoisier-Terrier sign. And then also on ultrasound, okay, so I think I screwed this up here. On ultrasound, the pancreatic ducts may be dilated, and the gallbladder will be found to be dilated and thin-walled. So gallbladder dilated and thin-walled, that's your Courvoisier sign, and the pancreas, the ducts will be dilated, especially if it's a cancer at the head of the pancreas. And that's just because it's compressing on the pancreatic duct as well. So 75% of pancreatic adenocarcinomas are in the head, and the other 25% are in the body or the tail. Symptoms include epigastric pain, just because of compression, back pain, weight loss, depression. We don't really know why, but with pancreatic cancer, depression is more common as a presenting symptom than with other cancers. Symptoms related to common bile duct obstruction would include icterus, jaundice, pruritus, dark urine, and light stools, and a palpable gallbladder. So all of that would be consistent with obstruction. And then thrombophlebitis, which is called Trousseau's syndrome when it occurs in the setting of cancer. That's going to be present in about 10% of patients. And then ascites may be present in some patients, but that's due to the malignancy. This isn't due to any kind of portal hypertension. So you're not blocking a portal vein or anything like that. What's happening is you have a malignancy, and that's causing an effusion into the peritoneal space. So you're getting your ascites. So remember your serum albumin ascites gradient. If it's greater than 1.1, then it's likely due to a portal hypertension. If it's less than 1.1, then it's more likely due to some kind of like malignant process or tuberculosis or something like that. And this is just the quotient of your serum albumin over the albumin in the ascites fluid. So for diagnosis, when you suspect pancreatic adenocarcinoma, the best initial diagnostic step is abdominal ultrasound, and that also is the best initial step when you have any patient that presents with obstructive jaundice symptoms. So here's your abdominal ultrasound that shows your dilated, thin-walled gallbladder. There is some sludge in the gallbladder. However, sludge just means that you've got a backup. It does not mean infection or anything like that. This is just from the obstruction, you're getting some thickened bile. So the abdominal ultrasound is the best initial diagnostic step in working a patient up for pancreatic cancer. It's not the definitive step by any means, but it's the best initial step. And what we're looking for is not the tumor itself, although you may be able to find it. We're looking for this Courvoisier's gallbladder, which is a dilated and non-tender gallbladder, as opposed to another gallbladder that you may see in obstructive jaundice, which would be normal or shrunken. And that kind of gallbladder would be more consistent with stones, because that's a more chronic problem, whereas a tumor develops over a course of months. So a dilated non-tender gallbladder, which is Courvoisier's sign, is cancer until proven otherwise. Is it always cancer? No, but it's cancer until proven otherwise. Definitely means you're going to be getting a CT. We'll also be looking for a dilated biliary and pancreatic ducts. That shows that there's blockage as well. So dilated common biliary duct, dilated duct of Wirsung, or your main pancreatic duct, and then fullness at the head or the tail. Now, usually, if it's a tumor on the tail, you're not going to get any blockage of your common bile duct or any Courvoisier sign or anything like that. The cancers at the tail are much more difficult to diagnose and don't present till much later. But if it gets large enough, it can. Fullness of the head, though, is where you'll likely see the tumor when it's a tumor of the head that's blocking the common bile duct and causing this enlarged gallbladder. So remember Courvoisier's law, and it's a law, quote unquote, because it's not all the time. It's just the vast majority of times. A dilated non-tender gallbladder is caused by a tumor, not a stone. So these are all relatively painless and possibly palpable gallbladders, this and this. These can both be palpable, and they're both painless. However, this here is a non-tender fibrotic gallbladder, and this is due to chronic blockage likely due to stones. This is a non-tender dilated gallbladder. They're both palpable, but this is a dilated gallbladder, this is a fibrotic gallbladder. And this dilated gallbladder is most likely due to a sudden, likely malignant blockage. And like I said, it's cancer until proven otherwise. So if you were to see this in this patient, then we would probably think maybe a choledocholiithiasis process going on, as opposed to if you see this in this patient, then we're definitely concerned about malignancy. Here's a CT of Courvoisier's gallbladder just to show you what it looks like. Obviously, it's ginormous. So this is at the level of the inferior liver, kind of very beginning of the kidneys here. So for diagnosis, when you suspect pancreatic adenocarcinoma, okay, I already said that. So best initial diagnostic step is ultrasound. Once you get the ultrasound, if you're suspicious of pancreatic cancer, i.e. you see Courvoisier's gallbladder, see a dilated common bile duct, dilated pancreatic duct, fullness at the head or fullness at the tail, the best next diagnostic step is abdominal CT. And this helps us do two things. It helps us get a better visualization of the mass in the ductal system to confirm our findings on ultrasound. CT is just more accurate than ultrasound. And it also helps us check for metastasis, which is going to be really important when we plan how we're going to treat the patient. Specifically, we're looking for metastasis to the liver. You should also get CA19-9 titers, and because that's the marker for pancreatic cancer, and possibly an ERCP. Especially if the patient already has this obstructive jaundice, we may want to place a stent. And when you're doing that, you can also get a biopsy if you choose, and usually you do choose. So here is a mass at the head of the pancreas and a common biliary duct dilation. So there's your dilated common biliary duct right there. There's your mass. And then here's a dilated pancreatic duct. I wouldn't worry so much about reading these perfectly, but definitely know where the pancreas, definitely know how to find the pancreas on a CT if it's given to you. Okay, so here's a tumor at the tail of the pancreas, and usually this doesn't present until later, so it's not surprising that there is already a metastasis to the liver. So the treatment. First off, what you need to decide, and this is why we got the CT, is whether or not we can resect the tumor. So we can't resect the tumor if there's metastasis to the liver. Nor can we resect the tumor if there's metastasis anywhere else. So extra-abdominal metastasis or extra-regional lymph node metastasis. If it's just regional lymph node metastasis surrounding the pancreas, we can resect that. But if it's extra-regional or there's metastasis to the liver or anywhere outside the abdomen, we cannot resect. We also can't resect if there is infiltration or involvement of the porta hepatis. So the hepatic artery and hepatic vein. Portal vein. All right, now if resection is possible, then the procedure we're going to do depends on where the tumor is. So if it's at the head, we do a Whipple's procedure. And what a Whipple's procedure is it's basically removal of the pancreatic head as well as removal of a lot of things that are around it. And then we sort of revamp the GI system. So I'll give you a picture of that in a little bit. If it's at the body or tail, it's pretty simple and pretty logical. You're going to remove the distal part of the pancreas, and then you also want to remove the spleen since that's in contact. And then this surgery is going to be followed by any of the below, usually chemotherapy. So if resection's not possible, the first thing that we know we can do is palliative surgery or care to just make the patient more comfortable. So if they have really bad jaundice, we can do biliary stenting, which can be done in ERCP. If they have outlet obstruction, which would be from the tumor blocking the outlet of the stomach, then we can do a gastric bypass. If there is significant pain, which there may be, then you can manage the pain. So this is all under the category of palliative care. We can also do chemotherapy, and we definitely do chemotherapy in patients after we've done a resection. Chemotherapy is part of the treatment, so we follow that by chemotherapy. But we can do chemotherapy alone in patients where resection is not possible. It doesn't have as good of results if you haven't already done a resection, though. So even in patients where resection was not possible, we can do chemotherapy. The chemotherapy varies. Usually it pretty much always includes 5-fluorouracil from the routines that I've read, but one of the new drugs that's being used more often now is gemcitabine. And you can also do chemoradiation, which would include chemotherapy along with radiation. But I just want to point out here, even in the patients that we do a resection, we still have to do chemotherapy too after the resection. Okay, so the Whipple's procedure. I'm going to talk about this a little bit more in depth because a distal pancreatectomy plus splenectomy is pretty straightforward. A Whipple's procedure is not very straightforward because it's named after somebody, and it's named after somebody because it's a very, very, very complicated surgery that it would be impossible to put it into an anatomic word. So Whipple's procedure is indicated most commonly for the localized adenocarcinoma of the pancreatic head, but it's also indicated for other cancers in that area. So cancers of the distal biliary tract, like a cholangiocarcinoma or an ampullary carcinoma, as well as duodenal carcinoma, where we would want to remove the entire duodenum. It has a 2 to 15% operative mortality rate, although it's probably more towards the lower side, especially if you're in a if you're getting the surgery in a center that specializes in this kind of surgery. What are we removing? So we're removing the antrum of the stomach, the distal part of the stomach. We're removing the entire length of the duodenum. We're removing the gallbladder. We're removing the cystic duct, which is part of the gallbladder, the common bile duct, and the ampulla of Vater. So we're removing the entire biliary ductal system distal to the common hepatic duct. And then we're also removing the head of the pancreas, which is going to include the tumor. Now, after we've done that, we need to create communication. So we have severed communication from the stomach to the GI system. We've severed communication from the biliary duct to the GI system, and we've severed communication from the pancreas to the GI system. So we need to create some communications here. We create communications from the pancreas to the jejunum, which is called a pancreajejunostomy. We create communication from the hepatic duct to the jejunum, which will allow us to get the bile into the intestine. And then we create a communication from the pylorus, the upper part of the stomach, the body, into the jejunum. So you're getting communication to allow your pancreatic juices, your bile, and your food that you eat into your jejunum. So we removed a bunch of stuff, but we created communications. So here is a picture of what Whipple's procedure would look like graphically preoperatively. So here's your gallbladder, and here's your stomach, and here's the antrum, and the duodenum here, and then the head of the pancreas. This is all kind of removed so you can see everything. These things are actually a lot closer. So we're removing all of these things here. Even though the cancer is just right here, we're removing everything in these areas because all of these areas could have cancer cells in them. So just think of, when you think of a Whipple's procedure, think of the head of the pancreas and a lot of the stuff that's around it, to put it simply. And then after the procedure, you have created a, so now this is jejunum here, not duodenum. So this is where the duodenum will go into the jejunum, and this is stapled shut. And now we have our jejunum. We're going to create a communication with the pancreas, the body of the pancreas here. The head of the pancreas is taken out. We're creating a communication with the common hepatic duct, the gallbladder, and the common biliary duct, and everything after that was taken out. And then also we're creating a communication between the body of the stomach and the jejunum. So this is the Whipple's procedure. Obviously a very, very, very complex procedure, and that's why it carries with it a mortality rate. Overall, though, the survival rate for pancreatic cancer, even following a Whipple's procedure, is only about 20% after 5 years. So pancreatic cancer is a relatively devastating diagnosis still today.